Good evening, everybody. My name is Roxanne Chabot from RBC Consultants. Welcome to another Skin Chat. This evening, we are going to try to answer the question, can skin changes associated with diabetes benefit from skincare? And we're also going to share with you the results of a multi-center trial. As guest speakers, we have Dr. Shasa Hugh, who's Associate Professor, Dr. Philip Frost, Department of Dermatology and Cutaneous Surgery, Director of Aesthetic Dermatology, and member of the Skin of Color Division, University of Miami Miller School of Medicine in Miami, Florida, as well as co-founder of BioLife. We also have Dr. Robert Kirshner, who is Chairman and Harvard Blank Professor, Dr. Philip Frost, Department of Dermatology and Cutaneous Surgery, Professor, Department of Public Health Sciences, and Director, University of Miami Hospital and Clinics for Wound Center at the University of Miami Miller School of Medicine in Miami, Florida. We'd like to thank our sponsors, CeraVe, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you would like to submit a question to our faculty, please submit your question in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will be emailed to you within 1 to 2 days. We would greatly appreciate it if you could fill out this short survey. Finally, within 1 to 2 days of the webinar, a recording and a certificate of attendance will be emailed to you. Again, if you would like to submit any questions to our faculty, please submit your questions using the question chat pane on the right-hand side of your screen. And I wrote a little note there so you could see where you need to type in your questions. So without further ado, I am going to pass the floor virtually to Dr. Kirshner.
Hello, everyone. Welcome. It's a pleasure to be here tonight and to discuss a very interesting topic, diabetes and skin disease and skin changes. And I'm thrilled to open tonight's webinar being the appetizer for your main course, Dr. Shasa Hu.
Oh, I think we have a polling question.
Yeah, so thank you, and I'll get the hang of the scrolling in a second. But here's a question that I wanted to start with, and try to get your intellectual juices flowing. Which of the following is not true about diabetic skin? Is there not increased transepidermal water loss, increased risk of infection, thinner epidermis, less corneocyte cohesion, or less inflammation? I'll ask you to vote. Okay, great. So we're going to have an interesting time. We certainly have a lot of opportunities for learning today, and we'll learn about transepidermal water loss, infection, epidermal thickness, keratinocyte cohesion, and inflammation as we go through this the next section. So what we hope to accomplish, Shasa and I, today is to talk a little bit about diabetic skin changes, talk about some specific things that can benefit from skincare, focusing on xerosis and pruritus, diabetic foot syndrome, ichthyotic skin changes, and keratosis pilaris. We'll talk about the lipid bilayer and how ceramides containing skincare benefits can affect diabetic changes, and show you some evidence around that, as well as showing you results of a cohort study that we participated as part of. Now, about 1.5 years ago or so, a multidisciplinary group of physicians got together. This included some dermatologists with a special interest in diabetes in the skin and some of the complications. For example, Gil Josipovich and Shasa Hu from the University of Miami. We had a number of podiatrists, such as Jason Hampton, Paul Kim. We had endocrinologists and wound care clinicians come together and write a review on diabetic skin changes and benefits that can be had from addressing this. And as you may know, about 30 million Americans each year suffer from diabetes. This can be a very severe and debilitating disease. And somewhere between 30 and 70% of those patients with diabetes may have some disease of skin condition, some skin condition. It may be mild, it may be severe and deforming, and it may even be life-threatening. And we also know that certain skin conditions can offer insight into patients' glycemic control and may also be the first sign of diabetes in undiagnosed patients. In fact, 1 out of 3 or 1 out of 4 patients with diabetes don't know they have diabetes until they develop the complications of diabetes. So recognizing these patients earlier can get to earlier treatment and avoid serious long-term effects, and also improve patients' quality of life. So recognizing skin disease is important. Now, why patients develop skin diseases is not always entirely clear. We do know that hyperglycemia contributes to some of the skin changes, and we also know that the epidermis is altered, and as a result, there's skin barrier dysfunction associated with diabetes. And we're going to delve more into this in just a moment. Jordan Rosen and others looked at the skin changes associated with diabetes and really divided them into 4 categories: primary skin conditions, and these include things such as necrobiosis lipoidica diabeticorum, diabetic dermopathy and bullae, things like eruptive xanthomas, perforating disorders, and acanthosis nigricans, xerosis, fibrotic and mucin deposition diseases, and lichen planus, all of which have some in cases very high association, and others with less association with diabetes. A second category was infections, including bacterial and fungal infections. A third area was the cutaneous manifestations of diabetic complications from either vascular disease, such as microangiopathy, or from neuropathy, including autonomic disease, which can lead to dry skin. And then finally, the fourth area, which is reactions to diabetic treatment with the drugs such as sulfonylureas and insulin. Now, focusing on epidermis and how the epidermis is affected with diabetes, it is. And interestingly, there's a disconnect, because on one hand, the epidermis is thicker, but the thicker epidermis does not translate into a better epidermis. It translates to a worse epidermis. There are alterations in certain of the epidermal proteins, such as filaggrin, which leads to barrier defect. And as a result of this, you have increased transepidermal water loss, because the barrier function is abnormal, and therefore skin hydration is diminished in patients with diabetes. Now, we do know that these diabetic skin changes that impact skin barrier function are in part related to hyperglycemia and impaired insulin signaling. And if you think about how insulin is important in cellular function, you can also appreciate that impaired glucose utilization in cells such as keratinocytes can lead to problems in the function of keratinocytes, which may lead to differences in skin proliferation and differentiation, all of which leads to this abnormal skin keratinocyte homeostasis, epidermal barrier function. And what we know is that long-standing hyperglycemia impairs barrier function and actually accelerates skin aging process. Now, part of the problem, and a large part of the problem, is this stratum corneum hydration state, which is diminished because of some of the things I've already mentioned, and I'll go into it a little bit more detail in a moment. But there's also decreased sebaceous activity. All taken together, you have drier skin, leading to xerosis and acquired ichthyosis, and especially on the lower limbs and on the feet, which has importance in patients with diabetes for foot ulcers. If you look at these electron microscopic images, on your left is normal skin that's smooth, and the lamellae are located between the keratinocytes or corneocytes, while on the right, where you have somebody with diabetes and ichthyosis, you have these undulations, which are altered lamellar organization and fractures across lamella. So you have ultrastructural changes that are really dying for a treatment such as moisturization, which not only will improve them, but actually will improve the well-being for patients with diabetes. Now, clinically, what we see when patients have these mechanistic challenges that lead to ultrastructural changes, they present with these skin changes, things such as xerosis, pruritus, diabetic foot syndrome, ichthyosiform skin changes, and keratosis pilaris, all of which may benefit from skin care that we can apply to the skin. So the common feature in these patients with diabetes, the common feature is xerosis. And what happens is there's an abnormal persistent cohesion between corneocytes. The cells stick together abnormally, but they're sticky. And it leads to secondary thickening of the stratum corneum, impaired moisturization of the stratum corneum. You get increased transit time of corneocytes in the stratum corneum, slower transit time, and altered skin barrier function. And interestingly, the longer and the more severe the diabetes, the worse the ichthyosis, as well as the worse in the microangiopathy. So if you look at somebody's skin and you see really severe dry skin, this can be an indication that they may have vascular disease and microangiopathy as well. Now, I showed you ultrastructural changes associated and electron microscopic changes associated with diabetes. Here's a cartoon that really kind of takes a little bit of a larger view and looks at, and shows that this epidermis that lacks moisture and has diminished sebum production, you have the scaling, issuing, and fissuring, and really you have a dysfunctional epidermis. And actually, the connections between the epidermis and dermis are also dysfunctional and may be in part the cause of the diabetic bullae that we sometimes see clinically. Now, as I mentioned, there's diminished skin hydration in patients with diabetes. And you can measure this diminished skin hydration by increased transepidermal water loss. The water is not captured within the epidermis, it leaks out. And this process of leaking out really is part and parcel, part of the dry skin patients who have diabetes encounter, along with their decreased sebaceous gland activity. So let's take a step back and think about what normally happens in the epidermis to maintain the moisture. And as you may know, this epidermis is often thought as a brick and mortar composition, the bricks being the cells and the mortar being the lipids, lipid bilayers that are in between the corneocytes. And the essential components of the skin lipid matrix are cholesterol, fatty acids, and ceramides, which actually make up the largest component of this, that play a critical role in stratum corneum structure. They regulate skin barrier homeostasis. And interestingly, when you look at characteristics of skin barrier disorders, including diabetes, you see a decrease in ceramide content. So what you have is an abnormal mortar, an abnormal lipid bilayer in patients with diabetes. The good news is that I'll show you in a moment, we can help this. Now, what patients experience because of this lipid bilayer dysfunction is they experience skin tightness, they experience their skin that feels shrunken and dehydrated, it feels and looks rough rather than smooth, and they may have itching and pain, which may be quite severe or intense in some patients. There's redness, there's inflammation, peeling and scaling. And this may lead to fine lines, cracks, and fissures and their consequences, which I'll discuss in a moment. And in some cases, some of these fissures are quite deep and may lead to bleeding in severe cases. Now, oftentimes, as I mentioned, this dry skin, this fissuring and cracking is worse on the lower extremity and feet. And there are a number of factors that in diabetics that lead to cracked heels. Standing is one of them, especially on hard surfaces. Diabetics are often overweight, and therefore their weight leads to increased pressure on the normal fat pad under the heel. The skin is not supple and flexible, so the pressure to crack is high. And it's even worse if they're wearing certain footwear, which allows the fat pad to expand in an open-heeled shoe, increasing the pressure even further, leading to cracking and fissuring. Now, the problem with cracked and fissured skin, especially in a diabetic, is this is a major risk for infection. Normally in the epidermis, our pH is a little acidic, and we call this an acid mantle. But the acid mantle is less functional in diabetics. Oftentimes, the footwear leads to a warm environment, and this warm environment allows fungus to take hold. The fungus may get in through these cracks, lead to itching. The itching may lead to scratching, and you get a cycle of cracking, itching, scratching, and worse cracking. And it may be, therefore, a portal for infection of bacteria that may lead to cellulitis, which can be quite serious in patients with diabetes. Now, in judging the severity of dry skin or xerotic skin, a simple system has been developed where people have mild, moderate, or severe dry skin based on characteristics such as rough and scaling skin, the presence of itching, the presence of pain, erythema, and fissures. And if you have mild to none of this, you may just have mild dry skin. If you have mild to moderate of many of these, you may have moderate dry skin. And when it becomes severe, then you're considered to have severe dry skin. And this can be a scoring system that can be used both clinically and in clinical evaluation. And therefore, we can address many of these factors that result or exacerbate dry skin through cleansing, through emollients, through moisturizers, and then through the use of either over-the-counter or prescribed topical steroids, as well as calcineurin inhibitors. And they each have a different role. Cleansers, obviously, they remove debris and may help remove bacteria. Emollients, such as mineral oils, may close fissures. But certain moisturizers are going to be critical as a routine to not only act as humectants, which hydrate the stratum corneum through a hydroscopic effect, increasing the elasticity of the skin, but also may be anti-inflammatory, either alone or in combination with other treatments. Now, one of the consequences of diabetes is itchy skin or pruritus. And it's usually due to two causes. One is dry skin I've been describing, and the second is neuropathy. And when it's due to dry skin, it may be generalized or localized, especially on the lower legs. And it's when in neuropathy, it may be localized in different parts of the body, including the scalp, the genitalia, or different areas of the trunk. The treatments are often addressed based on what's the cause. For dry skin, we talked about the use of moisturization. For neuropathy, topical capsaicin, topical ketamine, amitriptyline, lidocaine preparations, and oral convulsants may be used, such as gabapentin or pregabalin. And if secondary infection, whether it's a candida or a tinea infection, appropriate use of antifungals may be appropriate. So the appearance of this diabetes-associated pruritus is often xerotic skin. As I said, may be localized to areas of the scalp, ankles, feet, trunk, and genitalia. but it also may be generalized if the dry skin or xerosis is generalized. And the treatment, which I already mentioned, was especially for the severe pruritus associated with diabetes that's associated with neuropathy. These treatments may be appropriate. And the use of antifungals, again, when there's a secondary fungal infection. Now, I want to conclude by talking about diabetic foot ulcers, because this is a problem that is really unrecognized. There's a global pandemic. If you have a diabetic foot ulcer, if you have diabetes, you have a 1 in 4 chance of developing a foot ulcer during your lifetime. And if you develop a foot ulcer, that's bad. Why is it bad? Because it's associated with increased mortality, and every 20 seconds a lower limb is lost to diabetes, 85% of which are preceded by having a foot ulcer. So these are serious complications of diabetes. And we call this diabetic foot syndrome, which starts with, because of autonomic dysfunction in diabetics, they have dry skin, they have callus formation, and in a combination with diabetic neuropathy. And this insensate foot, often combined with ischemia, puts patients at exceedingly high risk for the formation of an ulcer and the complications of an ulcer. Now, the neuropathy, you may have an autonomic neuropathy, which I mentioned, may give dry skin. You may have a motor neuropathy, which may lead to bony abnormalities in the Charcot foot. You may have sensory neuropathy. So if you have trauma or damage to the foot, you may not even know it because you're insensate in that foot. And this is quite complicated. The approach to dealing with patients with diabetes-associated neuropathy and peripheral vascular disease is probably beyond the scope of this presentation. But I did want to highlight the role of moisturization, especially in patients with diabetes who suffer from autonomic neuropathy. Because if you can prevent the dry skin, you can prevent some of the complications, including development of ulcers and development of infections, both of which can be both limb and life-threatening. Of course, the areas that are most at risk are the areas where you get the diabetic foot ulcers. You're talking about the heels, on the foot, and also in the forefoot, depicted here, where high pressure areas, where you get a combination of the neuropathy, the xerosis, in combination with repetitive trauma to the feet, leads to hyperkeratosis and often underlying ulcer underneath the scalp. So what can we do? How can we be part of a multidisciplinary team that approaches this, that manages patients? Well, one of the important things that a dermatologist can do is really be at that forefront by recognizing the skin disease, appreciating that the skin disease can be a marker of diabetes and making sure they get diabetic treatment early. The dermatologist can also implement the skin care that can halt the progression of diabetic foot syndrome and lead to prevention and better outcomes in patients with diabetes. So I'm going to stop here, and I'm going to hand the virtual podium over to Dr. Shasha Hu, who will take you on the rest of this journey. Thanks, Shasha.
Thank you, Roxanne, for the introduction, and thank you, Dr. Kersner, for this wonderful review on the key pathophysiology and changes in diabetic skin, ranging from early symptoms such as xerosis to diabetic foot ulcer. Now, next, I'm going to start with a polling question. Which of the following factors impact skin barrier function? A, skin pH, B, composition of lipids in the stratum corneum, C, inflammation, D, application of humectants, or E, all of the above? This should be pretty straightforward after the excellent review by Dr. Kersner. Wonderful. I think we can all finish the seminar tonight and go home. Just kidding. So now, in the next 20 minutes or so, I want to present the data on how ceramide-containing skincare can be beneficial for patients with diabetic skin. So just to review on what Dr. Kersner has shown us earlier in this section tonight, the key strategies for patients with diabetic skincare in terms of skincare include a few items. First, of course, diabetic patients should focus on good glycemic control because high glucose level tends to trigger dry skin and decrease our skin's ability to defend against harmful bacteria, both of which increase a skin's risk for infections such as cellulitis. And when patients have diabetes, it's important to educate our patients to keep the skin clean and avoid macerations. So typically, we like to ask our patients to avoid hot bath or showers or long hot bath showers, as that can dehydrate the skin and lead to also maceration of the skin. Additionally, after each shower or bath, we like to have patients apply a moisturizer to prevent dry skin, as we know that preventing dry skin can put a stop to that itching skin cycle that can lead to increased infection, as Dr. Kersner has shown us. Additionally, it's important to advise patients to avoid applying moisturizer in between the toes because that can actually lead to maceration, which leads to overgrowth of fungal organisms and then can lead to infection and itching. And additionally, for patients who live in cold, windy climates, moisturization is very important because that can prevent chapping in the lower extremity and prevent development of ulcers or diabetic infection. And lastly, as Dr. Kersner has shown how important it is to prevent diabetic foot ulcer, we like to ask our patients to take good care of their feet. So visual inspection daily is very important in preventing early diabetic foot ulcers. Now, excuse me, I'm going to get hang of this mouse really quickly. Sorry about that. So let me go back one slide. Okay, so before I delve a little bit deeper into topical skincare for diabetic skin, I want to just review some of the key function and structure of the stratum corneum that Dr. Kersner has taught us earlier. So as you recall, stratum corneum is the very top layer of our skin. And in the stratum corneum, the key composition in between the corneocytes is the lipid bilayer, also known as lipid lamellae. So lipid lamellae composed of mainly cholesterol, ceramides, and lipids. Healthy lipid bilayer typically has a ceramide proportion ranging from 40 to 50%, while the rest of the lipid bilayers composed of cholesterol and free fatty acids. So what happens when our lipid bilayer contains a lower than expected amount of, I'm going to go back, of ceramides. Oh, sorry. I am so sorry. Okay, so as Dr. Kersner mentioned, that people with diabetes tend to have compromised skin barrier, and that is likely due to lower ceramide content. So when the ceramide ratio is decreased, we have a compromised skin barrier function, and that leads to impaired homeostasis, leads to clinically dry skin, irritation, erythema, and itching. And that can start a vicious cycle of dry skin, itch, and infection. And interestingly, in addition to diabetic-related cirrhosis, other common skin barrier disorders such as atopic dermatitis and contact dermatitis are also characterized by decreased ceramide content. So, and in addition to the integrity of lipid bilayer, we also want to think about skin pH. So skin pH actually is a very important part of our skin barrier function because skin pH influences not only enzymes that process and produce the important ceramide cholesterol-free fatty acids that form the lipid bilayer. Skin pH also affects the function of enzymes such as serum proteinases, which can break down our corneal desmosomes in the stratum corneum. Additionally, skin pH influences our skin microbiome diversity, and it's important to be aware that both exogenous and endogenous processes can influence the pH of our stratum corneum. So when we look at healthy skin, normal skin has a pH of 4 to 6. So that is slightly acidic. And when we look at simple skin hygiene process such as washing our skin or cleansing our skin, for example, tap water has pH that is typically neutral at 7 or slightly alkaline at 8.5, while most common over-the-counter cleansers or soaps typically have a much higher pH at 10 to 12. So when you look at simple hygiene processes such as washing, cleansing our skin, using tap water or alkaline soap, that process can significantly change the pH of normal skin, and that in turn affects the integrity of our skin barrier because, as we mentioned a little bit earlier, acidification plays a vital role in our skin barrier function. Other requirements for a competent skin barrier, in addition to maintaining a physiological pH, is that we need to also address inflammation. Reducing inflammation will help to calm down the activity of enzymes such as serum proteinases that can break down the lipid bilayer. Additionally, we need to look at how to maintain sufficient amounts of ceramides, free fatty acid, and cholesterol at the correct ratio for that functional skin barrier. So it's a very complicated process when we talk about hydration, skin barrier, and functionality of our skin. So what happens if our skin pH increases? A few cascade of events will occur. Typically when there is a elevated pH or stratum corneum, we have increased inflammation, and that leads to a feedback loop that increases the enzyme activity that breaks down our stratum corneum cohesiveness. And then additionally, we also have a process that result from elevated pH that leads to decreased production of ceramides, and that leads to decreased integrity of the lipid lamellae or the lipid bilayer. So in turn, we have dehydration of the skin, and that leads to dry skin and potentially itchy, scratchy, and damaged skin, and then the whole cycle ensues. So this is why we need to think about skin pH, inflammation, and ceramide content when we talk about how to maintain an adequate skin barrier function. And it's also important to know that not all skincare is created equal when we talk about exogenous processes that affect our skin barrier function, particularly in regards to skincare for patients with diabetic skin. So when we talk about topical skincare products, one of the key components of moisturizer, there are 3 main types of moisturizers. A simple occlusive emollient, so that's when we talk about Vaseline or Aquaphor, a simple ointment that forms a occlusive artificial permeability barrier on top of the skin. So in this scenario, the simple occlusive emollient helps to trap moisture in the skin, therefore increasing the hydration transiently. Now, when we make a more advanced moisturizer by adding humectants to occlusive emollients, here we not only have an artificial permeability barrier on top of the skin, we also have added humectants to help retain moisture in the skin, thereby increasing skin hydration. Now, in the last model, which is the most advanced model, here we're not only including humectants, but also we're replacing physiological lipids. As you recall, we mentioned that the 3 key components of the lipid bilayer or the lipid lamellae of the stratum corneum include ceramides, cholesterol, free fatty acids. So these are definitely very important to consider when we want to design a smart topical moisturizer. So when we add components that can replace or restore physiological lipids to the skin barrier. So here we're talking about an emollient containing both humectants and physiological lipids. Here we not only have an artificial top barrier layer above the stratum corneum, we also can restore the normal barrier function and then with added humectants to retain moisture. So this is definitely a more sophisticated delivery system and a moisturizer system. CeraVe has added to the advanced moisturizing system by its own patented multi-vesicular emulsion model. So here is actually very unique. The multi-vesicular emulsion system consists of multiple concentric circles that contain oil and water ingredients that gets released layer by layer slowly over time once it's applied to the skin. So this is in contrast to the conventional burst release model of the classic moisturizer. So when we look at the delivery system, again, the multivesicular emulsion releases ingredients slowly over time compared to a fast release and short release of the traditional moisturizer. So this becomes very relevant when I present the data a little bit later in this talk later on how CeraVe system is a little bit superior to the traditional emollients that release ingredients all at once. And how important the sustained release can be in terms of improving skin barrier function. I also want to emphasize there are some high advantages of the CeraVe technology in addition to the multivesicular emulsion system. So when we look at the global products under the CeraVe technology, all of the formulation have ingredients that are key or very important to this maintaining the skin barrier. And CeraVe products contain important subtypes of ceramides ranging from 1, 3, 6 to 11 that are very vital to the lipid bilayer. Additionally, CeraVe products are fragrance-free, which is really important for people with sensitive skin because fragrance can often trigger contact dermatitis. And most of the CeraVe products also contain hyaluronic acid and are non-comedogenic. And additionally, this is also very important for consumers, is that CeraVe products have a very limited composition of potential irritants on the skin, including sulfates, propylene glycol, or mineral nut coconut oils that can occlude the skin and cause comedons. So now I'm going to present some of the key studies that support how ceramides containing skincare can be beneficial to this restoring the skin barrier. So in the first study that I'll be presenting today is a single center study in which they evaluated the application of ceramide containing product, the effect of application on the lower legs of 49 women aged 30 to 65 with dry to very dry skin. So in this study, the subjects were asked to use twice a day of the ceramide containing moisturizer on the lower leg, while the other leg remained untreated. And evaluation will conduct at baseline immediately after first application, day 3, week 4, and at a 48-hour regression with bioinstrumental measurements at these time points. So this study focusing on women with dry skin, found that ceramide containing moisturizer significantly improved all aspects of dry skin, including skin dryness, skin texture, roughness, degree of desquamation, flaking the skin, and degree of erythema after 4 weeks application compared to baseline. And then additionally, at the 48-hour regression analysis, so that's when the subjects are asked to stop using the topical emollient for 48 hours. The study found that the improvements were sustained. So this is likely due to the benefit from multivesicular emulsion system in which ingredients are released slowly over time. And to correlate the improvement in skin hydration clinically, this study also found that biochemical exploration of the skin found an improved increase or significant increase in total ceramide content of the stratum corneum by 11% at week 4. So this was done by tape stripping study. So a piece of plastic tape were applied to stratum corneum, and then tape strips were analyzed to evaluate changes or proportions of the ceramide content of the stratum corneum that comes off of the tape stripping. So interestingly, not only there was a significant increase in total ceramide at week 4, there's also sustained increase of ceramide in the stratum corneum at the 48-hour regression. So this is very important data because sometimes patients don't apply moisturizer every day. So having that sustained benefit can be very meaningful for patient care. Now, the same biochemical exploration also found increased in cholesterol and free fatty acids in the stratum cornea at week 4, as well as 48-hour regression compared to the baseline. So this is definitely very exciting data. And additionally, photographic evaluation of the skin correlated with the biochemical as well as visual inspection of the skin, showing improvement in skin hydration as well as elasticity at week 4 and at the 48-hour regression analysis data point. So now the next study that I'll be presenting is a phase 1 RESTORE trial in which the investigators looked at CeraVe moisturizing cream and lotion and how the efficacy compared to 3 other over-the-counter control creams that don't have physiological lipids in their formulation. So in this study, the phase 1 RESTORE trial, the investigators found that the test cream and lotion both significantly increased skin hydration and reduced skin dryness for at least 24 hours after a single application compared to a no treatment site. And then additionally, CeraVe cream and CeraVe lotion performed superiorly compared to the 3 other control creams that lacked physiological lipids or also lacked the vesicular emulsion system. Now, I'm also going to present data from the RESTORE study phase 2 trial showing how ceramide containing moisturizer improves skin barrier function. So the phase 2 trial added more interesting outcome measures in addition to skin hydration. So in the phase 2 trial, this is very interesting data. So what they did is that they did tape strip on a treated arm as well as untreated arm and legs in the subjects who were asked to apply CeraVe cream, CeraVe lotion versus 3 other non-lipid containing emollients. So when you look at this graph, you can see that that CeraVe treated arm had a significantly lower transepidermal water loss at each test tape strip. So this means that the skin barrier is tougher. The skin barrier is more resilient and more resistant to transepidermal loss from physical irritation. And additionally, CeraVe treated arm had a lower rate of decrease or increase in transepidermal water loss compared to zero base, which is a classic occlusive emollient. So this is very interesting because not only we have data showing ceramide containing moisturizer can improve skin hydration, but this shows that improves skin integrity or resilience. Additionally, this report phase 2 trial also found that CeraVe appears to deliver more lipids into the skin based on biochemical analysis of tape strip. So again, here we have improved hydration, improved skin integrity, resilience to physical irritation, as well as improved content of ceramides and lipids. And additionally, the phase 2 trial found that stratum corneum hydration increased across all age groups from age 18 to 60 plus, with visual improvement in skin dryness in age groups with statistically significant difference in the younger age group. So again, we have all parameters improved significantly higher with CeraVe treated arm compared to a classic occlusive emollient. And then this last component of the phase 2 trial is actually what I found most interesting as a dermatologist, is that here what they did is that after 4 weeks of comparing the various topical treatment to non-treated skin, the subjects also received a small patch that contained 1% sodium lauryl sulfate, so which is a detergent, and that's known to be an irritant to the skin. And the patch was removed after 24 hours, and skin reaction were read at 48 hours. So this is very interesting. On the CeraVe treated area, subjects had a significantly less degree of redness, means inflammation, compared to the zero-base treated area. And additionally, CeraVe treated area had lower degree of transepidermal water loss compared to zero-base treated area. So what does this mean? To me, this means that ceramide containing moisturizing system not only helps with skin hydration, but also functionally it improves skin sensitivity, so that skin is more resistant not only to physical irritation, but also more resistant to chemical irritation, which can translate to a very meaningful clinical outcome, especially when we talk about patients with diabetic skin conditions such as cirrhosis, compromised skin barrier, or diabetic neuropathy-related diabetic skin syndrome. So in conclusion, so far the RESTORE trial has showed us that CeraVe delivers a barrier reinforcement compared to the classic occlusive emollient by increasing skin hydration water content, decreased skin dryness, and increased protection against irritation. And interestingly, patients also reported CeraVe was more cosmetic acceptable. So this is something that is very important to patients when we try to convince them to use a topical intervention. So not only is more tolerated, but it's also more preferred by the patients. So lastly, I want to present interim results from a global cohort on the management of diabetes-related cirrhosis to show you how ceramide containing moisturizer can improve diabetes-related cirrhosis. So this is an international multi-center control trial. The interim results are based on data from 352 men and women enrolled from 18 countries with both type 2 and type 1 diabetes. So in this interim study analysis, it was found that ceramide containing skin regimen that included a cleanser and a moisturizer significantly reduced diabetes-related cirrhosis by both clinicians and patients, with improvement in skin texture, itching, pain, erythema, and pruritus from both clinician perspective and patient perspective. And then additionally, Clinicians evaluated the improvement to be 2.21, which translates to much improved in diabetes-associated cirrhosis. Patients are also quite happy with the intervention of the twice-a-day skincare regimen of a cleanser and moisturizer. And what I found was very meaningful was that 97% of patients at the interim analysis report they will continue to use the skincare. So this means patients are compliant and they're willing to incorporate the skin regimen into their daily routine. So this also translates to potentially more successful intervention, because we all know that compliance is a very important predictor of the degree of efficacy of any topical intervention. So in conclusion, as we have reviewed in the past hour, diabetic skin conditions are very prevalent, but there's still limited data in understanding early stage skin disorders in diabetes. And we also know that disease control, early stage treatment such as skin hydration, ortho devices, and awareness can significantly reduce morbidity and burden of the disease in patients with diabetes. But it's also important that we have a better understanding of the burden of the skin disorder in diabetic patients to improve awareness in both providers and patients. And when we talk about how to improve skincare and prevent complicated skin outcomes in patient with diabetes, we should talk about how to optimize skincare using cleansers and moisturizers that can improve the quality of life in these patients. And we have shown you that there is evidence suggesting daily application of moisturizer containing ceramides and physiological lipids can improve a quality of the skin on compromised lower extremity in both in patients with both cirrhosis and diabetic skin. And lastly, moisturizer or ceramides can restore barrier and improve skin resilience. So that's sort of the highlights of the data I have presented. Now I'm going to pass the mic to virtually to Roxanne for question and answers.
Thank you so much, Dr. Hughes. So we have a bit of time to answer questions. Again, please submit your questions using the question chat pane on the right-hand side of your screens, or if you think of any questions afterwards, you can always send them to info@rbcconsultants.com. We'd like to thank again our sponsor, CeraVe, for making this educational event possible. So a couple of questions are here. Dr. Kirschner, can you give an example of how skin disease can predict the severity of diabetes?
Excellent question. So I often walk into a room and I'm talking maybe pre-COVID, and I'll shake a patient's hand and I'll put my other hand on their upper back. And what I'm doing is I'm feeling their upper back, and what you can feel is induration. This is a condition that's associated with diabetes. This is scleroderma aldatorum of Buschke, and it's associated with diabetes. The longer you have diabetes, the more indurated that skin is. So by simply touching their upper back, you can detect clinically the mucin composition of the skin. And diabetes, we focused on the epidermis, but diabetes also affects the dermis and what the production of fibroblasts are as far as mucin. And you can tell that a patient has diabetes, and then in fact they have long-standing diabetes because they present with this clinical finding. So something very simple as saying hello, you can make a diagnosis of long-standing diabetes in a patient with scleroderma.
Another question, are skin changes in diabetics independent of the presence of neuropathy?
Yeah, so the skin changes are multifactorial. They are complicated by neuropathy. So patients with neuropathy, we often think of diabetics having a sensory neuropathy. They don't feel their feet, so they get in trouble because of that. But they also have a motor neuropathy. If you look at diabetics' hands, their thenar and hyperthenar eminences are wasted. And they also have an autonomic neuropathy. They have dry skin. But independent of that, they also can get skin changes that you can see. For example, necrobiosis lipoidica is more highly correlated with microangiopathy associated with diabetes than it is associated with the neuropathy of diabetes. So both diabetes alone and in combination with neuropathy can lead to skin changes.
Dr. Hugh, for diabetic patients with dry skin, do you recommend taking fish oil to help with the dry skin?
So great question. I actually get asked about this pretty much 90% of the time when I see a patient with dry skin, not only in diabetic patients. So contrary to popular belief, replacing omega-3 or fatty acids orally does not necessarily translate to improved lipid bilayer content in your skin. But we do know that omega-3s as well as other fatty acids such as epigallinic acid can decrease inflammation. That is particularly important for cardiovascular health. That may translate to decreased inflammation in the skin, but the answer is likely no in terms of skin hydration.
Dr. Kirshner, explain how dry skin can lead to potential severe outcome in someone with diabetes.
So diabetics are at really high risk for infection. As an example, if you have onychomycosis and you're a diabetic, you're about a 4% likelihood of developing a cellulitis, which can be limb and life-threatening, which is much, much higher than somebody without diabetes. So by having dry skin, you have epidermal dysfunction. And this allows a fungus to worsen the dysfunction of the skin, and then subsequently bacteria to gain entry as a port of dry skin as a portal of entry for microorganisms that can lead to cellulitis. And again, typically it's an infection that tips somebody with diabetes over from having perhaps neuropathy and vascular disease into someone who may require an amputation. So this is really, really serious business. And we can't stress enough, as Dr. Hu mentioned, we can't stress enough how important it is to really take care of your feet in somebody with diabetes.
Dr. Hugh, what are some basic skincare routines that can help people with sensitive skin and diabetes?
Great question. It's a very broad question, so I'm just going to hit some of the key strategies. First, avoid things can dehydrate or irritate skin. So typically for patients with diabetic skin or sensitive skin, I like to recommend fragrance-free skincare products. Avoid hot, long showers that can severely strip away the ceramides and the sebum that naturally occur in your skin that protect your skin against infection or cirrhosis. And thirdly, especially for patients with diabetic skin, as we talked about how diabetic skin has decreased ceramide content, increased epidermal water loss, we should proactively encourage patients to moisturize, especially the lower extremities because of the risk for diabetic foot ulcer. So this definitely requires daily compliance. So we need to design a regimen that can be followed by patients that fit into their lifestyle. And then lastly, we have to educate patients to visit a dermatologist the minute they see persistent erythema, fissuring cracks because they're higher risk for infection. So we need to treat inflammation or compromised skin barrier more aggressively in patients with diabetic skin, in addition to maintain skin hydration barrier function.
And to make things worse, Roxanne, remember, patients with diabetes are at high risk for vascular disease, heart attacks, renal disease, peripheral vascular disease, strokes, and typically they're treated with statins. Statins also can worsen dry skin. So really, it's a perfect storm where patients with diabetes really need intervention that we discussed today.
Well, that's all the time we have together. I really want to thank Dr. Hugh and Kirshner for such an insightful presentation on the correlation between the skin and diabetes, and as you mentioned, a disease that is really reaching epidemic proportions worldwide. And I would like to thank you all for joining us, and to our American friends, happy Thanksgiving. Have a great week, everybody. Bye now.
Thank you. Bye, everyone. Thank you for joining us.
Happy Thanksgiving.